If I'm shooting free throws and I get up every day and I shoot 100 free throws and I miss 100 free throws, am I getting better just because I'm practicing free throws? No, I'm actually getting worse because I haven't had success doing it. When doing the lateral step down, if you want to maybe give them some type of assistance, I'm a big fan sometimes of using like an upper extremity assist to teach their body the position that they need to get in and out of. Having the patient have success doing it early on is super important.
Hey everyone, Doug Adams here with Scott Greenberg from Run DNA Podcast. Appreciate you joining us today here. We're going to talk about one of the most common injuries that we see in runners. We've talked about a couple different injuries we've seen before, but now we're really going to kind of dive into this most common one, and it's anterior knee pain. So this is something that if you guys have followed me, I dealt with a version of this. I had a partially torn patellar tendon, which would kind of fall into this group of pain in the front of the knee. So I've got a lot of personal experience with this, as well as a lot of professional, just working with a lot of runners. You're going to see this commonly. So I think there's definitely some things I've seen over time that really make a huge difference. And Scott, I'm sure you're the same. This is something that accommodates up to 30 to 40% of running injuries, a little bit more in females. So I think it's something we definitely want to address and make sure that people are getting a really good quality thing. So Scott, why do you think anterior knee pain is just one of the most common things that we see?
I think that that's a great question. If we knew the true answer to that question, we would probably be able to eliminate most of it, right? So I think it's multifactorial. I think it comes down to the relationship sometimes between weakness and lack of mobility, how those two processes or areas of things we need to address kind of come to the forefront. And I always say the knee is the dumb joint of the lower extremity, and my colleagues that I work with laugh every time I say it, but I do really believe that. I believe it's the dumb joint of the lower extremity because I think it's so depends on what's happening at the hip and what's happening at the foot and ankle. And me being a foot and ankle guy, I love to say that the foot and ankle is more important than the knee, but regardless.
Scott obviously didn't go to University of Delaware for PT school.
Correct.
Saying that right now here.
Correct. Yeah. So if the hip is not doing what it should do in controlling the femur, and the hip musculature controlling the femur, then oftentimes the knee can fall into too much valgus, right? And if the knee falls into too much valgus because of the lack of external rotation control or external rotation hip abduction strength, that creates a tracking issue sometimes at the patellofemoral joint. And likewise, if the foot and ankle is hypermobile and subtalar joint specifically is hypermobile, and you tend to see more of that internal tibial rotation, calcaneal eversion, again, you can sometimes see more of that valgus positioning. And then those two areas kind of contributing to that accentuating that problem of putting the knee in a non-optimal loading position. Now, I know there's a lot of research out there that goes into kind of combating that theory a little bit, like, oh, well, if we can control the pronation of the foot, then we can, with an orthotic, let's say, we could put the knee in a better position, and that doesn't necessarily always bear out, but I think sometimes it does, and it's a tool that I've relied on very, very heavily over the years to try to weed out why some of these things are problematic and how we can address it. We talk about asterisk signs all the time. Mm-hmm. You have a hypothesis, and that's what we do when we're treating a lot of running injuries, right? We have a hypothesis and we test it. We put out an intervention of some kind, and then we see if that change that we implemented went in the direction we wanted it to, right? So if I feel, let's say, the foot is creating excessive stress in one way, shape, or form about the knee, and I do something to change the foot position to a more optimum one in my eyes, and the knee pain is decreased, then I know I'm on the right track. And I can't say how many times this has happened for me, but anecdotally over my 25 years of practice, more often than not, I've had a lot of success with adapting, changing, modifying how the foot hits the ground to thus have a positive impact on what happens at the knee with regards to pain. Same thing at the hip, but I tend to find my best bang for the buck or my time Oftentimes, because I'm a foot guy, I like to start at the ground up as opposed to the top down. I've had great success manipulating foot to address knee.
So, I mean, I think Scott and I agree a lot on that stuff, but I kind of call the knee like the Dennis Rodman of running there. Like, it's an essential role player that you can't win championships without. And it might not be the star player of that there doing everything and hitting the game winning, but you wouldn't win a game without him. So I think it's because I think another way of saying that is the knee is kind of the workhorse, in my opinion. I think there's a couple things about it. Like Scott was saying, we've got this knee that is between these more mobile joints, the hip and the ankle, that are going through more motion, and there's less motion at the knee. But it experiences a lot of the stress of running too, and absorbs a lot of the forces. And I think when we think about anterior knee pain, I think about the role that biarticulate muscles play in running, and how they are an essential part of just creating motion, and in really just normal mechanics. And I think we have something like your rectus femur, like that is biarticulate muscle, and it goes across two joints, and the role that is, and especially with anterior knee pain, I think we really do see a lot more of the role of those biarticulate muscles and how they contribute to it. So that's what I've thought about, like, why are we seeing such high incidences? I think I would like to go back, and I'd really be curious to see decade by decade if anterior knee pain is an acquired type injury because of equipment or changes in shoe wear or things that we've been doing there. I think that's interesting. I'd be curious if when people started running in the 60s, 70s, was anterior knee pain the big issue then, or was it something else? Or if we acquired this as the most common injury because we have eliminated some of our ability to sense some of these forces that the body's experience, and therefore the joints aren't doing their job. Because I look at it as like the hip, you might say it's a dumb joint, but it's the one making up for everybody that's not doing their job. So if the hip's not doing its job, if the ankle's not doing its job, or the foot's not doing its job, then the knee is going to be the one that absorbs a lot of those forces. And it's the one that's really taking up a lot of that. So I think if we have reduced proprioception, reduced or higher forces related to higher stack height shoes and more cushioning, and are we acquiring this anterior knee pain because we just have changed the way we interact with the ground?
I think it goes in waves, right? So I think if we were to look back, just like the shoe technology has kind of changed a lot over the years, right? So I think there was a big uptick in like foot and ankle and calf injuries as a result of us trying to get ahead of the fact that there were so many knee injuries. So we kind of made some changes, and then we started to see an uptick in other injuries. So I think it all goes in waves. What is the first law of energy? Like, energy can't be created or destroyed.
Equal and opposite forces can't be. Yeah. Yep.
So with that, I think we're just robbing Peter to pay Paul, and it comes down to the bottom line thing that I say all the time, and it's the simplest way to describe all of this, is that when a stress exceeds a tissue's capacity, it breaks down. And however you want to kind of spin it, you run a certain way for a prolonged period of time, that capacity is going to be decreasing at a certain rate. And if you don't have the capacity to deal with the demands of the stress, it's going to create a problem. And depending on whether you're running on your toes or forefoot or switching to rear foot or putting a certain shoe on, all of that plays into different tissues bearing load, like you brought up. And we can do certain things to mitigate that. But at the end of the day, we need to build up our capacity.
And I think also when we think about why anterior knee pain is such a common injury, I think we have to consider from a epidemiology kind of standpoint here. I think the misconception that running it gives you strong legs, which is a myth, that running doesn't actually increase your strength. I think that's a big reason that anterior knee pain is such a prevalent injury, is because people think that they have strong legs and they don't spend time in the gym. And we know that the forces acting on the knee are very high, and people aren't building quad strength up or hamstring strength. They're not building the strength that they need to absorb those high forces
Hmm.
because their perception is like, oh, I have strong legs, I run. So I think if we were, I guess another way to phrase the question might be like, if you were to make a billboard to get people to do one thing to try to affect anterior
If
knee
I
pain.
was going to make a billboard for all
Yeah.
this, I'd say running creates skinny fat people. Right? Have you heard
Skinny
that?
fat.
Have you heard the
Yeah.
term skinny fat? Skinny fat
Yeah.
is somebody
Yeah.
that's
I've heard of it.
lean
Yeah.
and has
Yeah.
zero muscle mass on them, right? So,
Yeah.
running creates skinny fat people. That's not what we want. It's not an athletic build. It's not a strong build. It's just a skinny build. And,
Yeah.
you do
Maybe
see
fit to
some
run.
people that have really strong legs. I think more than anything else, that's like a toned, lean
Right.
region, but
Muscular endurance.
it's not a strong region, and I think oftentimes it can be problematic, like we talked about.
Well, and just from my own personal experience, right? I had a partially torn patellar tendon. I took off some time from running. And now, if you follow some of our other episodes, Drew Hunter, the former national record holder for the mile, is training me to run a fast mile. And when he first started doing it, if I am not doing a knee extension machine at least twice a week, I develop anterior knee pain. If I am not keeping up with the strength that was part of my rehab process, I will develop, like if it's been more than 3 or 4 days since I've done the knee extension machine, it's almost a guarantee that I'm going to get some anterior knee pain there. And it just
Mhm.
exactly like you're saying. And I think our billboard maybe I would do the coming from Delaware, maybe not say stim the quads, but I'd say strengthen the quads for runners or,
Mhm.
get in the gym, do something there. If we were trying to get rid of anterior knee pain, my billboard would be something along those kind of lines there. But it's interesting to consider where this comes from and what contributes there. And I think then that feeds into what Scott and I have been doing is, 5 things, right? 5 things with Scott and Doug. And I think we could talk about 5 essential aspects of anterior knee pain rehab. So whether you're a runner or you're working with runners, I think there's a couple things that we should think about and maybe give it a little extra thought and just say, obviously there's going to be some common things. And I think a lot of people know, uh, what you should be doing, but maybe some considerations of higher level things that having seen tons of these patients that we can give some advice that really makes a difference. So, for example, kind of the first thing, I think we're just going to talk about calming tissues down because when a runner comes into you, they really want to get back to running as quickly as possible. So when their knee is hurting, they can feel like every step is just unbearable there.
Mhm.
So, Scott, what are some things that when you're trying to get the tissues calmed down, what are some things that you really found? Maybe obviously people know to stretch the quads or stretch the hip flexors, things like that. But what are some things that we're thinking about? Maybe other ways to calm the tissue down and try and keep people at least participating under a reduced capacity level.
So I think there's studies out there that allow this to hold true, but um, hill running, for example, is a great way
Mhm.
to get somebody on a treadmill, let's say at a pretty consistent, comfortable pace. But if you increase the grade by I think it's like 3%, there's like a 27% reduction in knee pain, and if you increase the grade to 7%, there's a 46% reduction in knee stress.
Yeah.
So I think those are that is a wonderful tool to implement. Get somebody running up a hill because the demands on the knee are less. Now, again, be aware. No change without consequence. In
Right.
doing so, you're putting more stress on your Achilles tendon.
Yes.
And
Training.
so that is something to keep in mind. It's all about, and I say this every single episode, it's about shifting loads. Where
Hmm.
are we moving the load? So if somebody comes in with knee pain and we want to keep them running, we are going to take their knee and rest their knee. How do we rest their knee? Well, we're going to ask another tissue to step up and say, hey, help me out here. And in doing so, that particular tissue oftentimes is the Achilles tendon.
Yeah, we're gonna make a T-shirt up of Scott's head on like a bulldozer, somebody driving a bulldozer, like shifting loads around or shifting chairs on the Titanic kind of thing.
Mhm.
Because it's true though, like it's a great saying, and we do want to shift the loads around, and also ways to reduce the loads too, right? So I have seen some really good success actually with certain taping techniques. I have seen there's a particular tape. It was called dynamic tape. I don't know. I think it's called like biomechanical tape, or it might have changed
Mhm.
names, but there's an anterior knee pain taping that I do that is pretty magical for people. It is much stronger than like a KT tape. It's actually got tensile force in all directions, and I really like it. And I think we cover that is that in level 2, Scott? That we cover
Yes.
that taping.
Yep. Yep.
So we show you how to do that tape, and I tell you what, that has been a just an amazing tape that I've used. I originally, when I first came out of PT school, I did like a lot of patellar glide taping, where
Mhm.
lateral patellar glide taping with McConnell tape, and that worked a lot of times.
Mhm.
But I found it just comes off so
Mhm.
often that it was ineffective
And I
because
do
of that.
kinesio. I do some kinesio taping. Again,
Yeah,
we're gonna get some people out there that saying, "Oh my God, tape does nothing," and who knows what truly it does? Are we
yeah,
truly changing alignment? Are we truly stabilizing? I'm not 100% sure. Obviously, I have my thoughts on that, but at the end of the day, if you
yeah,
are able to implement a change, whatever that may be, and the bottom line result is the patient runner feels better and is able to do the activity for a longer period of time and more comfortably, then in my world, as a sports physical therapist working with high level athletes that need to be on the field or on the track, I'm doing it. And then I'm working on the other stuff that we always have to consider, which is okay, we did the tape. That's wonderful. What else are we going to do to really
right.
impact this runner, whether it be mobility, stability, strength,
Right. What does that
progressive
allow us to
loading?
do?
Correct.
Because it's not the answer. The answer is just tape your knee every time before you run. We're trying to maintain some aspect of fitness or performance.
Mhm.
And then on top of that, we're focusing on mobility, motor control, tissue capacity. Like it's a adjunct, not the treatment.
Yeah, I just don't. I get on my little soapbox. I come out of my corner fighting here when I start hearing people. It's like this all or none philosophy. Like, oh my gosh, we can't do tape. Patients, we don't know what the tape does, or we can't do this because patients become too dependent on us, or we can't do this because of that. We can do. They're tools in the toolbox, right?
Right.
Yes, we don't want to. We don't want to. We know for a fact oftentimes, I'm going to preach again, tissue capacity, get tissue stronger, load it if you can load it. All of that 100%. You know, stiff regions of the body create hypermobility in other regions of the body, right? The whole process of connection between joints and
Mhm.
um, they're all related, right? But the end of the day, if you have a tool in your toolbox that allows your patient to respond in a positive manner, um, why wouldn't you do it? I asked that question, like why?
Right.
What is the harm? Because they become too dependent on you? Okay, that's fine, but then you start weaning them off of it once they're able
Right.
to tolerate more and such. So I just hate it. Oh no, we can never ever do a dry needle. We can never needle somebody because we don't know exactly what's happening, or we're making the patient too dependent on us, and oh my gosh, we should never put our hands on a patient because soft tissue mobilization makes the patient too dependent on us, and we're not really moving tissue, and oh, we should never do a joint mobilization because are the joints truly moving, and all these different things that kind of people have brought to the forefront over the years,
Yeah.
and they're all tools, and in certain situations with certain patients, certain things work better than others, and I think the successful therapists are the ones that are able to draw on those tools to best suit each specific need for each
Yeah.
specific patient.
Yeah, a lot of those people that bring those kind of things up have never been like, I have a race in 2 weeks. I need to run this type thing. I've been training for 6 months, or I have Olympic trials coming up in 4 days and this hurts and I need you to like let me run. And it's like you need to have a pretty broad toolbox to get it there. Now, I think the trick with it, and this is something I've always tried in my career, because I hear that a lot about that with modalities as well too. And there's some
Exactly.
modalities that I found that work extremely well. in certain situations. But what I challenge people is to say, try to have at least a hypothesis of what situation each one works. When does taping work? When does Tecker work? When does dry needling work? Like, what situation are you going to use these individual things? Like, I tell the story. I had a high level runner come into me with bilateral femoral stress fractures and said, I need to run a race on national television in 2 weeks. And we used like a Tecker therapy there that like Winback that just he ran pain free and 2 weeks later. And that was one element of the whole treatment. But now I incorporate when I have bone stress injuries, I find that that really does help reduce pain and accelerate healing. So that's
Mm-hmm.
one part of my treatment. That's not all. He didn't come in and all I did was like, oh, here's 20 minutes
Yeah.
of a modality. Like don't you feel great type thing. We were working on gait. We were working on strength. We were working on mobility. We were doing everything. But you
Mm-hmm.
got to have those tools.
And again, I wouldn't be naive to say like I am lucky and fortunate to be in an environment where I don't necessarily have the time to do some of those things, nor do I have to do those things because I work very, very collaboratively and closely with a lot of athletic trainers. And,
Yeah.
I have maybe an hour or so with a patient, but the patient will sometimes get treatment after I'm done. After I finish with them, they go over and work with their athletic trainer for some other treatment, whether it be laser, whether it be shockwave,
Right.
whether it be, they get on the boots or whatever it may be. So I'm aware that I'm fortunate to have a lot of other tools at my
Mm-hmm.
disposal. But what that brings to me is that I feel like there are certain things that I find to be very, very important in
Yeah.
identifying what I can do from a treatment perspective to have the best bang for my buck. And that sometimes would include taping, that sometimes will include orthotics, that sometimes will include gait modification, that sometimes will
Yeah.
include soft tissue mobilization, but oftentimes includes joint mobilization and strengthening.
Yeah. Yep. And it's all, that's kind of the first phase that we talked about. You need to be good at calming tissues down too. Like, I
Mhm.
think that's an important part of it. And you need to have your tools and find out what works for you. And there's not one way to do it. So figure
Mhm.
out which way you can get results in, because sometimes your belief and the patient's belief in it is just as important as the actual methodology of it. So, all right. So the second thing here, I think there are some mobility restrictions that we commonly see with anterior knee pain. And so maybe Scott, you're the foot and ankle guy. Why don't you take ankle mobility and your thoughts on restoring that? And I'm going to take more like the thigh and like what we need to focus on there.
So restoring ankle mobility, I think, is roll up your sleeves and start working on that talocrural joint. I'm a big believer in making sure that I do a lot of mobilization with movement. I do a lot
Mm-hmm.
of independent mobilization using bands and tubes in which the band is kind of giving a certain directed force, and then their body is moving in a similar or different opposing force direction to try to facilitate some more capsular movement around the talocrural joint. And then
And
again,
I agree with that, right, too. And one
Mhm.
of the things that I think, if we're kind of thinking about like, okay, that's like the staple here. If we're thinking about some of the clinical pearls that maybe if you don't use this a lot, you might not see. I think when getting ankle mobility back, I think you really have to look at the foot mobility as well at the same time.
yeah, making sure that they're getting their first rate of the
That
ground,
they're
making
getting,
sure that they're able to hyperextend or extend off their first MTP again
yeah,
is super important because if they're not getting that true, very good normal push off, sometimes they're going to actually create more of a whipping motion, which is going to
yeah.
cause their knee to go into more of a valgus position. So yeah, making sure that their first, obviously dorsiflexion we talk about, but yeah, making sure that their first ray mobility is good, making sure that they've got adequate extension of their first MTP, making sure, I look oftentimes at calluses on the bottom of the foot to help me
Hmm.
with tell my story. So oftentimes if somebody's not getting adequate first toe or first ray extension, sometimes I will see more of a callus underneath the second and the third metatarsal heads as the foot kind of goes into this, I call it a whipping motion or a medial whip.
Hmm.
So those are big things. Sometimes they'll show a callus on their medial aspect of their hallux
Yeah.
as a result of them pushing off the shoe and twisting. So all of that, yes, all of that is stuff that I really kind
Oh,
of
midfoot
identify.
too. I'll give Chris Johnson a little credit with this. I love his mobilization that he puts out there a lot, where he has like a bent knee, foot flat on a table, and you kind of grasp the midfoot, and the patient kind of wags their knee in and out there with it. I
Hmm.
found that that's a huge part of getting full dorsiflexion back. I feel like that's a great mobilization. He's got some good courses out there as well, just about
I do a
different
lot of
exercises and treatment. Yeah.
calcaneal rocking. I have a whole bunch of calcaneal rocking type of things I do. I'll keep the foot flat, and then I'll also take the tibia, and I'll
Yeah.
internally and externally rotate the tibia. Sometimes if I'm trying to promote a certain motion, I'll actually get them on an incline or a decline board, using the board and gravity as to my help, to try to facilitate a certain movement. So if I'm trying to really facilitate um, uh, pronation, let's say, sometimes I'll get them more into the decline position where their foot is kind of facing down and the board is kind of situated a certain way where when I internally rotate the tibia, it really pushes that
Yep.
talus down. So depending on what
The
you're trying
mitred
to
hinge
do,
joint. Yeah.
yeah, you just kind of
Yep.
manipulate your environment to help facilitate and again take some of the load off of you and let gravity do its thing, right? So
Yeah.
um, I think all of that comes into play. But yeah, sure, the foot and ankle needs to move a certain way and
Yep.
properly to make sure that certain joints above it again are not dealing with that excessive load as a result.
Yeah. So I guess the takeaway is don't forget about the foot as you're trying to get ankle mobility
100%.
back with that. But ankle mobility is so important for knee because if you can't progress over the ankle as needed there, then what you're going to see is that you're often going to go into rotational positions, and then you're putting shear stress on some of those anterior knee structures. So restoring the ankle mobility is important because of the mechanics. And if you can't progress the tibia over the ankle there, we're going to see the foot externally rotates, the knee internally rotates. We're going to see some of those collapsing type mechanics, but it could be mobility related and not motor or mobility or motor control related there. So you have to kind of consider that.
Mhm.
When we think about the thigh, I think a lot of people think about the quads a lot as well, but I also didn't see like focusing on posterior chain is also very important with anterior knee pain. And part of that is I think we should really check. And I don't think people often look at this in an athletic population, but I do look for symmetrical knee extension. I think
Sure.
that that's important and look to see if they're getting into that position. And I am looking at posterior chain just for mobility, like hamstrings. I think there is some literature showing hamstring tightness as one of the predictive factors of those who go on. I think they said I was looking at one article the other day, and it was if they can't get to 70 degrees in like a active straight leg raise where they have the knee 90-90 in supine, and if they can't get to 70 degrees, so basically if they lack 20 degrees of hamstring flexibility on a hamstring flexibility test there, that they're predisposed to this. And that makes sense too, because everything in the body works in opposing forces. So we have an agonist and an antagonist. And if you're really tight on one side, are you weak on the opposite side, or you lengthen on the opposite side? So I think hamstring is an important part of this. And a lot of people will incorporate different quadriceps exercises, and I'm a big proponent for that in this group as well. But I think deadlifting and this maybe is going to bridge our gap into the tissue capacity and loading.
Mhm.
But I think deadlifting is an essential part because we know now that strengthening is equally as good at gaining mobility as stretching is. So I think if the two are really created equal there, then I want them doing deadlifts to try to get the tissue capacity and the tissue extensibility.
Mhm.
So that's just kind of my thing that a lot of people kind of tend to forget about the hamstrings a little bit, and they think about quad and they think about those kind of exercises. And I just want to say, don't sleep on the posterior chain as well.
Mhm. I think we
Yeah.
also just in general, we need to, because running is that prolonged activity with a lot of loads, we need to make sure that our tendons are able to deal with those loads. And not only
Yeah.
from a rehabilitative standpoint should we be working on, progressive loading of the tendon, but I think from a prehab standpoint, I think doing some of the open chain leg extensions putting the tendon under duress to
Yeah.
help strengthen it in preparation for the demands we're going to put through it, I think is something we should all consider. That's why, again, one of the reasons, again, why I love leg extensions are one of those things that became the like it was like a 4-letter word for so many years because people started getting away from it and people started taking, leg extension machines out of their clinics and everybody just had to squat and do leg pressing. And I think open chain exercises,
Are
serve
important.
a purpose.
Oh yeah. I mean, so back in, I think it was 2012, I published the guidelines for UD ACL rehab protocol. And I remember the big thing was I had Lynn Steiner Mackler and colleagues and everyone was saying like, we need to really make a push to promote open kinetic chain because it's becoming a 4-letter word basically instead of a 3-letter word. It's a 4-letter word there to do that. And we did a massive literature review and really proposed that. And I think that, amongst many other things, were really helpful to start getting people to put those things back in favor. And it really does make a big difference with it. So
Mm-hmm.
I think we have to have those open kinetic chain as part of the conversation. And so we've kind of transitioned into the next category, which is loading and tissue capacity. And, one of the things I think just an exercise I really like for this population that there's probably some people thinking out there right now, I don't have, like I was victim of that witch hunt on the knee extension machine and I don't have one in my clinic.
Oh,
So what
really?
do I do? Like I see that a lot in clinics. I go. One of the first things we got lucky. When we had Omega Project, we
Mm-hmm.
bought a knee extension machine off of a local gym that went out of business, and we got this amazing knee extension machine. It's like I've never found one as nice as this one, but we
Mm-hmm.
got it for a good price. But there's a lot of people out there, and I like a kneeling eccentric quadriceps exercise if you don't have a knee extension machine in your clinic. I think you can do some isometric kind of stuff, and that's also another alternative. But I think that where you just get in a tall kneel, so you're on both knees, and you keep your back straight, arms across your chest, and you just lean back, and then push through your ankles to bring yourself back up, is a great knee extension exercise that's working it eccentrically, similar to how it functions in running. And I think that that's an important aspect too that people can do if they don't have a knee extension
So,
machine.
so here's the thing. So, and I don't disagree, and creativity. There's a lot of different ways to skin the cat, right?
Yeah.
But we as sports physical therapists need to know, and this is where I'm going to get a little soapboxy again, but
Yeah.
we need to know that there are certain tricks to the trade. Like you're not going to be a surgeon without a scalpel, right? You're
Yeah.
not going to be
Oh, you're preaching to the choir now, Scott.
yeah,
Here, the
you're not going to
greenhouse
be
guy. Yeah.
you're not going to be a hairdresser or a barber without scissors, right? So
Right.
there are certain tools like and there's a whole conglomerate of therapists out there that will say you can't be a sports therapist unless you can, qualitatively and quantitatively test return to sport criteria, right?
Yeah.
So you've got to be able to put an objective number on a strength test, let's say. So
Yeah.
handheld, manual muscle test days are out the window. Let's get a dynamometer on it, those type
Dynamometer.
of things, right?
Yeah.
So along the same lines, if you don't have a leg extension, I think you need to figure out a way to
To
replicate
make
that
that
movement
happen.
to make that
Yeah.
happen. And there's a
Yeah.
lot of different ways, and they're not expensive ways. Some of them, like I said, are rack attachments. Some of them are, you can get one for $300 or $400 that aren't
Yeah.
that expensive. You can get some that are obviously the ones that are pin loaded are more expensive than the ones that are plate loaded. But I think it's one of those things, and it's one of the things even at the college that I work at. One of the weight rooms didn't have one because they're so dedicated to squatting and deadlifting and
Yeah.
trap bars and all these other stuff. However, recently they actually went out and purchased a couple of them because they felt the value, and especially in a sport such as basketball where there's a lot of running, jumping, hopping, you
Yeah.
need to be able to load those tendons, and they felt the need to bring that back. So I was happy to see that. So again,
Yeah.
it's just one
I
of
mean,
those
I
things.
could go off on a whole soapbox about saying like, hey, listen, if you really want to see a certain population, you need the appropriate tools. I think
Yeah,
I've kind of built a career around that actually.
yeah,
Say like, listen, these tools are important. And if you really want to be the go-to, like you really like, if you want to see a couple athletes, great. You can probably get away with doing a knee extension. But if you want to be seeing athletes all day, you need to do this. If you want to be seeing runners all day, you probably need the right tools there.
Yeah.
But
So back in the day, we say if you want to do if you want to treat ACLs, you have to have a Biodex or an isokinetic machine, right? I
yeah,
think right now you can get away with not having that if you have some kind of dynamometer setup where you can actually test the quad
yeah.
strength, right? So
And we
there's
have like a $400 dynamometer in my clinic that works great. And we're
yeah.
able to test a lot of different things. I was testing my knee strength when I was having all the issues there. And
Mhm.
it's some objectivity and it's striving for that. But
Mhm.
we do a lot of ACL return to running.
Uh-huh.
They get cleared before they come to us when they do that.
And I always say, like, if somebody tells me they have a sports medicine clinic and I walk into it, I can tell you within 13 seconds whether or not it's
Yeah.
that person there is truly a sports medicine person or not, based on
Just
the tools that they have at their disposal, right?
yeah.
If they don't have anything higher than a 10-pound dumbbell, if they don't have some kind of bar with loadable plates, if they don't have a squat rack of some kind, if they don't have a leg extension machine, if they don't have, those are just some basic things that are needed as tools of our trade, I'd say, to classify ourselves as sports physical therapists.
Yes, I agree. All right, along those same lines, I think it would be good to talk about, and when we're talking about loading here, and obviously we're not being all inclusive about how to treat anterior knee pain. This isn't a masterclass on that. This is more of like a make sure you're thinking about these aspects. So I would say, let's talk about the knees over toes. What's your thought on that, Scott? Because I think it has become back popular, and I think that there's it's going kind of both ways with it there, right? I think people are going from one extreme to the other with it. So what's your thoughts on it before we share mine?
When I first started out as a therapist, we were always taught, don't let your knees get in front of your toes. Don't let your knees get in front of your toes,
Yeah.
right? Whenever you're squatting or doing a heel tap or whatever. And now we're starting to go the other way. Make sure your knees go over your toes, right? So again, I agree with you. There's some kind of happy medium, depending on what you're trying to accomplish, right? What are your
Right.
goals of that particular exercise? And I think we talked a little bit before off air, like, is it imperative for you to get your knees over your toes so you can dip your knee in a pool, let's say, or dry, while you're squat? No, you don't need to go to that extreme. However, having the ability to control the movement of taking your knees over the toes, doing a functional activity, I think is important. And I think it stresses certain tissues more than others. And I think in doing so, you can again target your rehab appropriately.
I think, there's a spectrum, and when we're treating anterior knee pain, we're going to have to consider the spectrum of that okay, in the early phase of rehab, we might avoid some of those deeper knee flexion positions because it's going to put a lot of patellofemoral joint contact pressures.
Yep.
So that might be something, but also that shouldn't be conveyed as you can never do this again, or your knee's going to blow out type thing. I think we went from that extreme early on, and now the pool dipping your knees, standing on the edge of the pool and dipping your knees extreme, where you don't necessarily have to go seek out those movement patterns. You should not restrict from doing those movement patterns either. If you do a lunge, if you do a step up, if you get out of a chair, your knee is going to go over your toes, and that's okay. And I think we should be focusing on how we can incorporate those in at the appropriate stage of rehab,
Right.
because they are functional in that position, and we do want to develop as much capacity as we can. Although, it's interesting for the runner case because we're not really going into all that much knee flexion during stance phase when we're on the ground. So it might not be something that you need to push for, but if somebody's having pain with daily activities of getting out of a chair, or somebody's getting pain going up or down steps, then we probably need to incorporate that later into the stages of rehab, even if it's not something that is specific to the sport that they're trying to. If some of their activities of daily living were affected, then we need to consider that in the later stages of rehab.
Mm-hmm.
Yeah. Along the same line, like kind of the fourth one was motor control. And I think there's a lot of aspect of controlling at the hip, right? We talk about proximal stability here and how we really want to engage glutes. And we've been talking a lot about quads and hamstrings and calf muscles, but I think we do need to give glutes their due diligence there. And although this still is fairly knee dominant, my go-to for motor control that I start with is just a lateral step down from
Mm-hmm.
about 3 inches or so. I want to see that they can absorb and generate force through gravity that way, and that they can control it. And I'm watching, are they keeping their hips level? Are they going through some posterior weight shift? How's the pelvis moving? Is the knee collapsing in? I think that that's an exercise that holds a lot of value that
Mm-hmm.
people just kind of go through the motions with, and could be such a valuable part of rehab that it's one of those, if you do the exercise correctly, you get a lot out of it.
Mm-hmm.
If you don't do the exercise correctly, you might as well not do it at all.
Mm-hmm. Agree. It's diagnostic as well as a great, it's a assessment tool as well as a treatment tool all at the same time.
Yeah. And the
And
other
I
thing,
think with it, not to interrupt you, but I think with it, if you're using it as an assessment tool, that's one thing. But also when you're doing it, having the patient have success doing it early on is super important. So, I always say, if I'm shooting free throws and I get up every day and I shoot 100 free throws and I miss 100 free throws, am I getting better just because I'm practicing free throws? No, I'm actually getting worse because I haven't had success doing it. So when doing the lateral step down, if you want to maybe give them some type of assistance, I'm a big fan sometimes of using like an upper extremity assist to teach their body the position that they need to get in and out of. And there's a balance component to it as well. And you kind of take that out of it. And again, it's more of that graduated progression of success, success, success. But how can we make this more difficult as time progresses while making them somewhat successful at doing it so that we can reintroduce those proper patterns?
Yeah, meet them where they're at. Make
Mm-hmm.
sure that they are getting some momentum and finding some wins, and they're not just focused on the gap of where they want to be, but they're focusing on how they're gaining right there. So yeah, I agree with that. And that's, I think Scott and I both agree on this because level 2, we talk about the loading levels. And this is a precursor before anyone really does any true jumping or plyometrics. They need to be able to do this exercise correctly. I think that's a huge part of this too. And this is before in the loading levels, which if you haven't taken the certified running gait analyst courses, that's our way of prescribing the appropriate amount of plyometric and jumping based activities for a runner to make sure that you're meeting their current capabilities. And the first one is the lateral step down, because before I'm going to look at them with box jumps or hurdle jumps or hopping or anything like that, I want to make sure that we really truly understand what their capacity is. And I think this is a great way to get started with that. So I also, just talking about glutes as well too, I think you can call it the running man, but the hip abduction isometric against the wall is just there's so many variations on that exercise that I love.
Mm-hmm.
There's a lot of great ways to do that. And I think that that's a great way to learn how to control the knee and mimicking mid stance of running there. And also engaging the glute and getting some proprioception about where your body is in space. So that's just a go-to.
I've been doing a lot more of that particular exercise of late. Really, it's really in my it's in my circle of common exercises now that I'm doing a lot more of. Yeah, I have been. I use like a mini foam roller to help them kind of roll up and down the wall. So they push into the foam roller like we're talking about, and then they do like a little bit of a mini squat while they're still applying force to the wall. And I do it all the time. I agree. I like it.
I think we use like a Pilates ball or something for it there. They give nice, you just need a little give, and it's a great exercise. So one that's all throughout the courses there. All right. Final one here, gait analysis and gait mechanics here and how this contributes to anterior knee pain. I'm going to share just like a quick story that just talks about it. And part of the reason that we developed these running gait categories is to simplify it and to prioritize what you need. So I had a guy come down. He was a big time executive at a very wealthy company. And he said, "Hey, I'm going to run this marathon. I can't run more than 5 or 6 miles right now without the front of my knee hurting. I got a bet going with my buddies. I need to be able to run this marathon and beat them. So he booked 2 days of my time and said, great, like, fix me, like, do whatever you need to do, fix me. So we go in, we start off with some assessment. We start talking to him about his training and all those things, and everything was lining up pretty well. So I put him up on the treadmill, and he's got anterior knee pain, and it looks like straight out of Weekend at Bernie's. He's leaned back. He is just in a trunk extended posture there, putting like feet landing way out in front of him. And I say, all right, hey, why don't we do a 3D analysis? And we kind of verified what we saw. And then I said, all right, why don't you just try running like you're running uphill, or running like you're leaning into a stiff wind? And he said, oh, my knee pain's gone. Said, okay, run a little bit longer. Let's kind of watch it. So I did another 3D analysis and verified that he improved whatever we were looking at. And then he runs for 5 miles, and it's like no knee pain. So he comes back the next day. We run another 5 miles on the treadmill, no knee pain. And it was so simple, and it was easy, and the knee pain was gone. And I think that that's something with understanding and the role of gait analysis in treating anterior knee pain should not be undervalued, because it is such a valuable aspect of treating anterior knee pain, because there are some things that are just so easy to fix and so easy to treat.
Mm-hmm. Agree. We've all had our wins using different tools in different ways. And again, no two runners are the same. They right. all have their own unique kind of style and strengths and weaknesses and leg lengths and all of that. But there are some commonalities, like we say, like the overstriders, the people that have excessive vertical displacement. Oftentimes I see being an issue.
Yeah.
The bouncers of the world. So there's a lot of different things. People that have too much collapsing mechanics, again, can be a component of it. The wonderful work that Brian Heiderscheid did with, increasing cadence is a great tool to kind of go to, the 10% increase to get people to shorten their strides, land closer to their center of mass, land with a slightly more flexed knee. All of that kind of comes and can help out a little bit. So, whether it be using a metronome or whatever kind of tools you have at your disposal to assist with getting them to land closer to their center of mass, are really, really helpful tools. And I've found over the years to be extremely beneficial when dealing with anterior knee pain.
Well, you just listed 4 of the 5 categories of the main categories, right? Where we were just saying, okay, hey, and that's a question we get a lot. I don't know if you get this one as much too, but people are always asking me like, well, if I'm an overstrider, like, does that mean I'm guaranteed to get anterior knee pain? And it's like, we just listed how anterior knee pain could be for overstriders, for bouncers, for glute amnesiacs, for collapsers. Like, we listed 4, and it really depends on.
You can throw the weaver. Did you say the weaver? You can throw the weaver in there too. It's too much transverse plane motion. Too much transverse plane motion is not great for the knee. So absolutely,
so 5 out of 5, right there could be with that. But I think having the categories and being able to convey that is really helpful, because we don't want, like, when we're throwing all this stuff at a runner, I think it's important to not overwhelm them also with all these things, because typically we just listed all 5. Typically, when that runner with anterior knee pain is up there on the treadmill, they're going to have at least 3 out of those 5 categories kind of going on at once that you could argue there. And then your job is to prioritize which one you think is the biggest contributor to it, and figure out how to make a meaningful change with it. But I think gait analysis is such a critical part of anterior knee pain that people really need to make sure that they're doing that and getting people up there on the treadmill and looking at it and see if they can change their form.
Great.
Yeah. So hopefully, Scott, any other thoughts on anterior knee pain? Hopefully this is just a good overview of, if you're seeing this commonly, maybe you picked up a few tips or tricks that Scott and I do, or some other thoughts or considerations. I know, like Scott was talking about, is rotation of exercises. I know that's very common. All of us therapists, we'll kind of get in the habit, I don't want to say rut, but we'll get in the habit of using certain exercises. So hopefully it's helpful to hear some different ideas, and we'd love to hear what else is working for people. Leave some comments, either on the podcast or on the YouTube channel. We'd love to hear more. It's something we know people are seeing commonly here, and we should all be sharing what's working well. Yeah.
Yep.
Anything else, Scott, or that covered it for you?
I was just gonna say, don't forget that we're all therapists at the end of the day, and not all anterior knee pain is the same. Some is more tendon related, some is more fat pad related, some is more joint or patellofemoral joint or tibial-femoral joint. So there's different components of it. It's not all the same. So if you've got a tendinous issue, make sure you're treating the tendon the correct way with a lot of the common things that we have found over the course of our years doing therapy, whether it be progressive loading, eccentrics, low and slow, whatever it may be. It could be all of those, right? But make sure you target the tendon. If it's a tracking issue, again, if you feel it's a patellofemoral tracking issue, make sure you address the things that you feel can help with that. And just, don't forget that you're still therapists at the end of the day, but there's a lot of different things that you should be looking at, not just the knee specifically.
Yep. Well, thanks for listening. If you're still listening, you obviously like hearing what we have to say. So check out the newsletter too on rundna.com. Make sure you're signing up. We've got lots of other content we put out through there, as well as on social media with Instagram. So check out YouTube channel. A lot of these exercises that we talked about, we actually have for free on the YouTube channel. So if you're looking for the hip abduction isometric, you're looking for lateral step down, those are there so that you can share them with your patients too. So be sure to check that out as well. And thanks for listening. I hope you have healthy and happy running.
Take care, guys.
Like what you hear? Leave a review of the show wherever you listen, and don't forget to subscribe so you never miss an episode. Run DNA helps runners and running specialists through education and technology to identify each runner's unique injury profile to avoid setbacks and maximize results. The Run DNA podcast is produced by Ace Running LLC. The Run DNA podcast is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can occur. Always seek the guidance of qualified medical professionals before making healthcare decisions. Find us online at rundna.com.